Good evening. My presentation is on the disease of hepatitis C, and I would like to cover the aspects of the pathophysiology, physical assessment, diagnostic testing, and pharmacology. I would also like to review 2 case studies to show an example of the different types of management that are targeted to be patient-specific. So this is where we're going to begin our presentation. Hepatitis C is a single-stranded flavivirus. It is enveloped and has positive sense RNA. So unfortunately, the hepatocytes are the target of this virus. Once it gets in there and goes through translation, what happens is it triggers an inflammatory cascade. When that happens in the hepatocyte, that can lead to fibrosis and also loss of liver function. Typically, you're not going to see someone come into clinic and say they're having an acute hepatitis C reaction. That is very rare. The diagnosis can be done historically. Some people remain asymptomatic for quite some time. In about 10 to 15% of patients, you might see some symptoms, flu-like illness, yellow sclera, some abdominal pain, nausea, vomiting, and they may complain about having a dark-colored urine. People that have had hepatitis C for a long time would have far different symptoms than someone that was just undergoing what they felt was maybe like a flu. They would experience spider angiomata, pulmonary erythema, muscle wasting. They could have asteriscus, which is like a tremor noted in their hands, caput medusa, ascites, enlargement of the liver, and potentially splenomegaly. Diagnosis is pretty comprehensive. Obviously, you want to look and see if there are antibodies to the HCV virus. You're also going to do a viral load, which looks at the amount of virus or HCV in the body. You're also going to want to do the genotype. The genotypes go from 1 through 6, and some of the treatment, at least in the past, was driven by whether it was genotype 1, genotype 3, what were the symptoms, and what is it resistant to. So that's really important in identification of that. Then there are going to be some routine lab works. Because of the importance that the liver plays in our body, you're going to look at the CBC because the liver has an impact on everything. It has an impact on albumin, on clotting, on coagulation, our platelet function. So those labs are going to be looked at, the prothrombin, the platelet count, the CBC. We're also going to look for concomitant diseases like hepatitis A, hepatitis B, HIV, syphilis, and also the alpha-fetoprotein. The targets for some of the other communicable diseases will be focused on lifestyle and patient history and risk factors. So all of this is important to discover because we want to be able to treat the people appropriately, not be making errors in that. And some of the other more invasive procedures like a liver biopsy, you would want to perform that if someone had known fibrosis. The liver biopsy is very good at staging the fibrosis. And then if you also knew or suspected that they had some portal hypertension based on some other symptoms, you could do an abdominal ultrasound, which would be very beneficial in that identification. And this is just a continuation of the labs that I have already reviewed in the biopsy and ultrasound results. Pharmacology, again, like I mentioned, it's really important that you know the genotype. Some of those, even some of the newer antiviral therapies are targeted based on the genotype. And prior to some of the newer ones, the regimens were very complicated. They might involve a series of 3 drugs and other things, especially if they had concomitant infection with hepatitis B or HIV. Some of the guidelines are really nice and user-friendly. You can search on those on the internet. For example, there's some PEG interferon, which was like the only drug available, maybe 10 years ago. So that was a combination therapy that we use now. if someone has HIV. So that will be one pattern of treatment. The ribavirin that goes along with that is a nucleoside analog. And what that does, it stops the viral spread inside the body. Although the exact mechanism isn't completely known, it does inhibit the viral RNA polymerase and protein synthesis. The current therapies that are the direct acting antivirals, the DAAs, the difference in treatment is really impressive because interferon treatment went on for 24 to 48 weeks. And the side effects with interferon were really like bone marrow suppression and suicidal ideation, so they were pretty severe. So now this new treatment with the DAA, you can go in there with something like sofosbuvir, and you're going to have a 12-week treatment therapy with one pill a day, which is a combination pill, but it's one pill a day for 12 weeks versus being treated for 48 weeks. And for some people that have problems taking pills anyway or sticking to things, this is wonderful rather than having to do something for 48 weeks. These are just examples of some of the medications that you can use. Sofosbuvir is a prodrug. The other direct antivirals, there's lots of them are there. And is some examples of, in pregnancy, there's certain medications that can't be given. So that would have to mandate a pregnancy test prior to starting any therapy. And then LFTs would be drawn prior to starting that medication. And then again, you'd have to draw them at regular intervals as well. Another good thing about the antivirals is the lesser side effects: fatigue, headache, nausea, nasopharyngitis. A little bit easier to deal with than thrombocytopenia, depression, and bone marrow depression. Safety for the patients is a hallmark of care for treating for HCV because of concomitant disease, numerous drug interactions, and adverse drug reactions by the treatment itself. So obviously we want to keep people abreast of that and what's most important. We want to counsel our patients and provide opportunities for them to ask questions, get the questions answered, and also pull in, any type of expert, GI, infectious disease, what have you, to make sure that these patients have the best chance of being safe in their medication profiles. Education involves, what do you do when you're taking these medicines and you don't feel good? Well, take a little nap or rest. It's important to do that because you're going to feel achy and maybe just not feel so great. So it's, great to work in that little bit of rest time. It's also good to be active because that's going to enhance your sense of well-being. And again, it's always important with medication to stay hydrated, 6 to 8 full glasses of water every day. Keep that hydration up. If you're achy, feeling bad, you can take a little bit of acetaminophen. That'll relieve those flu-like symptoms. However, ibuprofen is a negative because of the clotting factors and concerns for coagulopathies. So again, patient education is so important to cover all of those little simple points. Management plan. Ideally, what someone is going to do is they're going to have access to a hepatology clinic, which is great because then you have an interdisciplinary team, which would include the prescribers, physicians, nurse practitioners, and clinical pharmacists. Some of the research that's been done with the clinical pharmacists has been very positive because they're such great educators. Who better knows medications than a pharmacist? They can sit down with the patient, go over the medications. They can help them with self-management guidelines. They can help them understand adverse reactions, what to do. They can look at drug interactions. All of these things are so, so important for these patients. And the research has shown that patients that have the clinical pharmacist as part of their interdisciplinary team have better adherence and they have greater satisfaction with their treatment for HCV. So this is so important to have for the patients. The first case study is just going to highlight Miss Fields. She's recently been released from prison. She's currently on probation. She's got a court date in 6 months for a new charge of drug possession. She was diagnosed in prison with HCV, and she's here for her first appointment in the hepatology clinic. She's HIV negative, so we will not be suggesting anything to do with the PEG interferon and ribavirin. She had a negative pregnancy test, so if Simipravir would be something that we would want to go with, full speed ahead. And she's 36. She does not have any other comorbidities. She does have a history of sharing needles and has a history of alcohol. And as we know from the past, these individuals cannot drink alcohol because that will accelerate their liver fibrosis and complications, and certainly is a contraindication with the medication regimen that we're going to have. What we're going to do for Ms. Fields is, it's great, she's genotype 1. What we can do for her, she is a Medicaid patient, so she has the opportunity to take the sovosbuvir combo with belpatasvir. So that is the first pan-genotypic single tablet regimen for HCV. So this is a wonderful opportunity for her. It's also very good because it's a short course, 12 weeks, which is perfect for anyone that might have some questionable practices. The cure rate is over 90%. Again, which sounds good to somebody. Hey, we want to get you well. You're not going to take this pill and only have a 50% chance of getting better. We're going to give you better than a 90% chance of getting better. Some of the studies have even gone up as high as 95%, which is really exciting for them. So the biggest contraindication, if we start her on this medication, would be amiodarone. We want to rule out any type of cardiac problem or any concern that she's taking amiodarone, or will need that in the future. That would cause a fatal bradycardia. So that's a definite contraindication. Antacids are okay, but they need to be separated by 4 hours from this pill, because the pill is geared on what the acid level is in the stomach when it's ingested, which should not be a problem because it's a once-a-day therapy. So it does make things like, if someone does need to take a Tums or something like that, it would be okay because they're not worried about having to take something every 8 hours. And again, the side effects are very low with this medication: fatigue, headache, nausea, nasopharyngitis. So for Ms. Fields, counseling with adherence and staying on target, keeping her appointments, understanding that some of her lifestyle choices will not be acceptable with this treatment program. She will have to stop drinking alcohol because that will give her the best chance for a complete recovery. And it is difficult with someone that does have a history of incarceration and poor lifestyle choices. However, some of this adaptation may help her. And if we can give her emotional support, give her enough education, and also guide her to some community resources that may help her to get to appointments, or get to the pharmacy, or any type of community resources that we can refer her to that would help keep her compliant, would be in her best interest, and also with us, because we want her to be successful. So the next presentation will be at a different end of this continuum for hepatitis C treatment. This is Mr. Benz. He's 57 years old. He's from India. He went in to donate blood for a neighbor and found out he's HCV positive. So he's at his clinic. This is his 3rd appointment. He's going to go over his liver biopsy results. He has significant fibrosis. He's genotype 3, which means that he also has an increased steatosis. He's been asymptomatic. He had a blood transfusion in 1990, and this is one of those individuals that just did not develop symptoms of the HCV. Unfortunately, he has progressed from that first insult to what we would call chronic HCV. So unfortunately, this man has all the risk factors that go with this chronicity, including a risk for developing a hepatocellular carcinoma. His fibrosis is at the later stage. He has a genotype of 3, which makes his treatment modality a little more frustrating than would it be for someone else. And even if he had an elevation in his ALT, which he most definitely does, it's not necessarily indicative of how bad the HCV is. So unfortunately for Mr. Benz, he is going to be recommended for his treatment modality, a liver transplant. And if you look at everyone that is developing HCV, which is a large percentage of the population in different countries, not just the United States, but Egypt and India and everywhere else, the goal for liver transplant is almost impossible to keep up with that because of all the individuals that would be on that list. But nonetheless, we'll do symptomatic management and recommend him for liver transplant. So as you can see, the two cases are very different. You have one that people might have a stereotypical picture of someone with HCV, someone that, you know, has been in prison, maybe she spent some time on the streets, she definitely has a substance abuse problem. So this might be an unfortunate stereotype, which is a misnomer with the hepatitis C, because the baby boomers, those individuals born from 45 to 65, are very vulnerable to this. Anyone that's had a blood transfusion, an organ transplant, or some type of transplant of clotting factor, or back in the day when tattoos were not regulated and regimented the way they are now, also was vulnerable to contracting hepatitis C. So, you know, it's not necessarily everybody that has hepatitis C is automatically has a label of they're a bad person. That would be a misnomer. So, but we do have to look at these folks and what we can do best to help take care of them. Who's going to be the most compliant? Who needs the most education? Who needs the most support? What do we have to do to eliminate their failings of having a stigma? You know, for an older gentleman to suddenly come down with HCV, you know, you have to feel, does he feel conspicuous? Is he going to want to seek treatment? Is he embarrassed? So we really want to be sensitive to that in our patients. We want to do the best we can to give them as much support as we can, encourage adherence to any treatment that we devise for them, and proceed from there. So if you look at Miss Fields, looking at her, she's got a great chance of success, 95%, if she adheres to the treatment. However, Mr. Benz, who didn't have any bad risk factors, he's probably just going to go ahead and get progressively worse with more symptoms because of the incidental discovery of the disease in his body already wreaking havoc. So unfortunately, it's not necessarily a fair, it's just not fair sometimes. I mean, if you think about it, oh, I live my life okay, but you know, it happens and it's sad. So here we are, we're looking at this. Again, we're looking at lifestyle, we're looking at psychosocial, we're looking at socioeconomic and insurance or lack of insurance. Medicaid will cover this, which is good, but people that don't have insurance, how are they going to get treatment? These pills are ridiculously expensive. It's $1,000 a pill for some of the new antivirals. And some of the treatments can go up over $100,000. So they go anywhere from like $74,000 up to $112,000 for some of these treatments with the new medications. And so since you have some of the people that are impacted with this disease, might be on Medicaid, might be incarcerated and homeless, you have things happening in the state. They're trying to put restrictions on the treatment because of the cost and the history of substance abuse. And we as prescribers have to look at the ethical implications of that and decide, is this where we are ethically? Is this the stand we want to take? Or are we going to treat our patients and hope for the best for them and give them the best possible tools in their kit to get the best possible treatment? And I think we need to be attentive to what our states are doing to ensure that we are compliant with the treatments and can protest if it comes down to a breach of ethics. Thank you so much for your attention. I hope you enjoyed the presentation.